Hey, this is Elliot. Oops. Hi, this is Elliot Fishman, and welcome to our Facebook Live. I'm coming to you straight. I'm home today, working away, and I got my official The Fish hat on, so I thought I would wear it. It's my grandson gave it to me, so I have to wear it. I'd like to welcome everybody here. Hope everyone's doing well as we I can't say we're winding down COVID. We're going to a different stage, which is also challenging as you see a lot of the states, 8 states in particular, Arizona, the Carolinas, places that are opened early are having all sorts of issues. So hopefully we'll be able to solve that problem. Again, this is also the last week, and most of our fellows have left. A couple are still around, and our new fellows are starting. So it's going to be somewhat challenging for all of us to get through the new year. And we welcome all our fellows. We had great fellows this past year. I always like to put on CTisus, depending who the fellows are. Um, it's either that Ray Charles song, Hit the Road Jack, Don't Come Back No More, No More, or it's Lulu to Sir with Love, where we're sad to see them go. But I think this year was more of a Lulu, sad to see it go, and we wish everybody the best of luck. I see Mark DePaulis, nice hat, thank you. All right, I'll take the hat off. My hair's all messed up. I'll put the hat back on. Okay, so anyway, I'm supposed to talk about renal masses this week, and I think of all the topics probably renal masses is in some sense the easiest and the most controversial, and at the same time being the most important. The number of patients we do, the number one reason for a CT in the ER setting is hematuria. We know hematuria often is stone disease, and of course that's a non-contrast CT only. It's also probably the only time you want to do only a non-contrast CT. But as we all know, hematuria is also a good sign for malignancy, particularly macroscopic hematuria. Patients over the age of 50, there's almost a 30% chance of a macroscopic hematuria being malignancy. And even patients who are younger with macroscopic hematuria, there's still going to be up to a 20% chance they have a malignancy. So the question is, how do we evaluate a kidney? So there's different protocols, right? There's hematuria, rule out renal mass. We have a symptom, but that could be a bladder cancer, it could be a ureteral cancer, or it could be a renal mass, be it renal cell or transitional cell. We also would do cases of the kidney where someone had a mass seen on a routine abdominal CT, an MR, or an ultrasound where it really wasn't fully evaluated. So it's very important to fully evaluate renal masses. Okay, so what do we do? If I want to evaluate a mass, now this is not an incidental finding, or maybe it was, we need to evaluate it further. We always mention that we will do a non-contrast scan through the kidneys because many lesions are going to be benign and they're high density cysts. If you know something measures under 20 or over 70, it's homogeneous and well defined, then it's going to be a benign cyst. The higher numbers over 70 are a high density renal cyst. The low ones are more typical cysts, right? So that becomes very important. Also, when I have a non-contrast scan, once I give the contrast, then I can look and see, does this lesion enhance and how much does it enhance? Lesions like clear cell renal cell carcinoma enhance to an average attenuation of 160 and papillaries 90, chromophobes to about 100. So not only could we say the patient has a mass present, but we could say specifically what the mass is. So I'll do my non-contrast, then comes the contrast part. So contrast is very critical. You need good IV access, okay? Ideally, a minimum of a 20 gauge or an 18 gauge would even be better, unless you have some of the newer catheters, the Nexiva catheters, which have the side holes, then a 20 works well because a 20 you can do up to 10 cc's a second. So I want to inject 5 cc's a second. Depending on how your hospital does things, there's two contrasts you can use. One is Omnipaque 350, one is Visipake 320. So depending on the patient's renal function, patient's history of allergies, patient's other risk, are they older patients, are they pediatric patients, are they on chemotherapy, you kind of come up with some risk strategy and you figure out which contrast to use. Now, in terms of quality of study, if you gave me 100 Visis and 100 Omnis, I couldn't tell the difference. So both of them give great studies. Again, the key thing to me is 4 to 5 cc's a second injection rate. Again, we aim for 5. And then we start scanning. So we typically will do a timing because I want to have the things simple, similar from case to case and make it simple. 30 seconds is a great arterial phase. Now, arterial phase or cortical medullary phase, whatever you want to call that 30-second image, is critical because it gives me a lot of information. First of all, it shows me the arterial structures really well, the normal ones, the renal arteries, aorta, any feeding vessels like an AVM, but also gives me a very good feel of how vascular a lesion is. One of the things I think we've spoken about on CTisus, and I'm sure many of you have read about, is that how we can predict the tumor specifically based on density, how high it enhances. Remember, over 100 will give you a 99% chance or 98% chance that it's a clear cell. And many clear cells enhance into the 200 range, typically. The other thing is a number of articles have shown now that based on the vascularity, we can predict what chemotherapy will be best for the patient. Using AI, we can predict the survival of the patient. So one of the key things is getting the right protocols, and arterial phase is very important. People often would say, well, I just get 60-second. No, you need arterial phase. First of all, you'll miss some tumors. Truth is, you'll miss some tumors on any single phase. But arterial phase, you could hide very small vascular lesions that are at the cortical medullary interface. But at the end of the day, it's really the vascularity that becomes so critical to me, also in terms of staging and in terms of surgical planning. Remember, the goal now is to do a partial nephrectomy, unless you have to do a nephrectomy because there's no choice. But partial nephrectomies are the way to go. The American Urologic Association says it's partial nephrectomy are less contraindicated, like maybe the tumor is spread too far, big contraindication. But with a partial nephrectomy, the surgeons need to know the vessels very clearly so you can create spectacular 3D imaging from the vascular map. So that becomes very, very important to me. I think it's something you need to really focus on. The other thing is, I'll bring it up here, is you need to do 3D imaging to really evaluate a renal mass. A combination of MIP and volume rendering, perhaps cinematic rendering, gives you some textural analysis of the mass, gives you the vessels really well, and that'll be true as we go to venous phase as well, both arterial and venous. So that becomes very, very important. You can't do better than that. And then I'll come back at about 60 to 70 seconds, probably closer to 70. That's the venous phase. Okay, 70 seconds is really good in terms of if you have a mass looking at its venous involvement. Venous phase is where you can look at the renal vein best. Is there renal vein thrombosis? Is there a clot in the renal vein? Is there a tumor in the renal vein? And of course, in terms of lesion detection, some tumors show better venous than arterial. I do like arterial. Now, one thing I will do is if patients are young, let's say under 35, we try to minimize dose to those patients. And so I might only do the arterial phase and not do the venous phase. That's the protocol listed on CTisus. Now you can say, why don't I do the venous phase and leave out the arterial phase? I think the arterial gives so much additional information. And if your only concern is going to be lesion detectability and classification, if I combine arterial with delayed, I think I'm in great shape. So I think that would work really well. Now you get down to the delayed phase. So what do you do with delayed phase? Well, delayed phase, several very important things. Some tumors only show well in delayed phase. Remember, we also said that infection, pyelonephritis, is best seen in delayed phase. It may only be seen in delayed phase. So you can get around some of the problems perhaps with making the wrong diagnosis and calling something a tumor when it's really not by having that delayed phase imaging. The other thing, delayed phase imaging, why it's mandatory, is we talk about transitional cell carcinomas. Now, transitional cells involve the calyces. It involves the renal pelvis. And particularly smaller transitional cells may only be seen on expiratory phase imaging. If somehow or other you were doing arterial and venous, you'll do pretty well in detecting most tumors and classifying them, but you're going to do terrible on transitional cells. You're going to miss many of the lesions, and particularly with TCCs being multiple, be it in the kidney or contralateral kidney, or in the ureter or in the bladder, delayed phase becomes very critical. Now, there's always a controversy of how delayed is delayed. I like to do 5 minutes, 4 to 5 minutes, but let's say 5 minutes for a moment, because the contrast is not that dense. So you don't have beam hardening artifact. Things come out very, very well without any of the problems you typically would associate once you have beam hardening artifact, you're never really sure what you're looking at, and things become a little bit trickier. And you're not sure, is there pyelo, is there tumor, is it partial averaging, is it, so you end up with a really woozy report, which the clinicians really do hate. So those are the phases. Now, to me, one of the things, if I stick with the excretory phase, as I just mentioned, because you want to look at the ureters, the renal pelvis, and the bladder, is not always going to be filled, because we know that because there's transitory changes in peristalsis. But if there's a tumor in the ureter, things are dilated. And so I look at the ureter. Even if it's not opacified, I look for caliber, I look for changes in density. And so I'll look for anything that could be secondary signs of the patient having a mass present. Very similarly, I would look at things like on the venous phase, principle, looking at the veins, looking at the renal masses. Again, looking how a lesion behaves from arterial to venous becomes very, very, very important. And so that becomes a very, very critical factor. So to me, that is exceedingly important. So you really need to be looking at that carefully. I mentioned before, we acquire, obviously it's axials, but you must look at the coronals. The coronals are critical for detection of things in the cortical-medullary interface, critical for looking at the arteries, the veins, looking for renal artery stenosis or aneurysms or pseudoaneurysms. And then the venous, of course, looking at the renal vein. You want to be careful, you're not looking at flow-related changes in the vein, but you're really looking at something that could represent thrombus. So coronals are critical, and in excretory, coronals are critical for the same thing, looking at the calyces, making sure there's no papillary necrosis, making sure there's no transitional cell tumor. All of those things become super important. So then you say, okay, so now we have this multiphase. Now, how do I minimize dose? Well, you select the right parameters, but it's what you scan. If it wasn't for contrast, people would, for radiation, people might scan from the diaphragm to the symphysis 4 times. So non-contrast, we do the kidneys only. When we do arterial phase, we'll do from above the kidneys down through the symphysis. If we come back with venous, we'll do venous from above, mid-liver, above the kidneys, down to the crest. Excretory phase will go from above the kidneys down through the pelvis. So we minimize the volumes of scanning for the sequences. That becomes very important, and I believe can be very helpful. So that works out really, really well. Now, again, people have questions they can ask them. Besides Mark DePaulis, Mark's from GE, and GE has really helped sponsor CTisus. We really thank him and GE for all their support, even in these difficult times. Tardy phase around 10 minutes. I don't do anything. 10 minutes is a terrible phase. Many people suggest, well, if we 10 minutes, the ureters will fill in better. The reality is that's not the case. Once the kidneys are excreting contrast and they're not obstructed, it's a dynamic function. So you may have bad luck. The ureter may empty just because it's peristalsis. The same thing as if you're obstructed. If you're obstructed, we know from IVP days, it can take hours for the contrast to opacify the ureter. But to me, I look at the ureter because I'm looking for soft tissue masses. I'm looking for caliber changes. If there's a mass in the ureter, you're invariably going to see textural changes. Now, I'm optimizing. Satomi Kawamoto wrote an article, 95% of the time we can get a great study. It is important to have the ureters opacified because I will look at those with MIP imaging, and sometimes very early transitional cell, which occurs in the ureter, is not appreciated in the axials and is best seen on the MIP imaging. So we need to do that routinely. Again, the pelvis, the calyces, things from tumors to papillary necrosis to strictures, all of them are seen better when you use the multiphase and you use the post-processing and the correct displays. So that becomes very important. Obviously, things like transitional cell versus clear cell, the appearance is different. Now, I will say there are some challenges. What's a chromophobe? That is a challenge. What's an oncocytoma? We'll talk about that in more detail later. But I thought this one I was really going to focus on the renal cell, again, making the point to you that detection is critical, and then, of course, staging. So staging, we look at the liver, make sure there's no liver mets. We look for adenopathy, both in the paraortic region as well as the pelvis. We'll look at the adrenal glands. Of course, we also will do similar protocols in patients who've had nephrectomies or partial nephrectomies. There, except for the first time, you might not bother with a non-contrast. But again, arterial venous delayed becomes very, very critical. The 10 minutes, why I don't like it is the contrast is so dense that you have beam hardening. And sometimes you can't tell, is there something in the calyx or not? Or you're overcalling something in the renal pelvis because of beam hardening. I don't like to be with very dense contrast. People have written articles about using denser contrast in Europe, particularly 400. It's craziness because that 350 or 320 work perfect with giving you enough density, but not too much. And so if you look at CTisus, you'll see a lot of cases. I posted a bunch recently on renal masses and some of the values of the different phases. There's a couple good lectures on CTisus on renal masses. The new version of CTisus lecture series should be out within about a week on the Apple Store, and that will help because that really also we put away some of the older lectures, revamp things, so a lot of really good new lectures. So that should be very, very positive as well. And again, you really need to understand these protocols and how to do the studies because the kidneys are such a big part of what we do. It's one of the most common exams, as we said on CT, particularly in the ER setting. So whether it's the ER techs or the techs in your outpatient center or your techs in the hospital, everybody needs to be on the same page and know precisely how to do the study. So that's kind of what I thought about speaking about. If anyone has any questions, this is a good time. I know people are busy between summer vacation starting, which is a misnomer maybe this year, but just getting people in and out can be a challenge. So if there's no questions, if you have some, just email me and I'll try to answer them. If not, have a great day and we'll see you next week. Bye.